What exactly are ovarian cysts and when should they raise a red flag? Hello, wonderful friends, and welcome back. I'm Dr. Emma Mary, a board-certified gynecologist, and today we are going to have a thorough conversation about ovarian cysts. Honestly, this is one of the topics that causes the most anxiety in my practice. I see patients daily who are absolutely terrified by this issue. The moment they hear that four-letter word, cyst, it sets off alarm bells and causes immediate panic. But I want to assure you that there are some fundamental basic facts about your anatomy and what these structures actually are that can really help demystify the situation and calm those fears. First and foremost, I want to remind you that I am a fertility specialist, and this channel is entirely dedicated to helping you understand your reproductive health and your fertility journey. If you find this type of educational content helpful and you want to support this mission, please make sure to hit that subscribe button and follow along for more deep dives into your body. Now, let's start right at the very beginning. In its simplest terms, an ovarian cyst is essentially just a radiological finding. It's not necessarily a disease or a disaster. A cyst, by definition, is simply a structure that is filled with some kind of fluid or a semi-solid substance. It is a pocket or a sac that contains this liquid-like material. When you think about it, your entire body is capable of developing cysts in various places, but the ones we hear about most frequently are ovarian cysts because they are directly tied to the incredible, intricate process of our reproductive system. The absolute number one cause of ovarian cysts is something we call a functional cyst. These are incredibly common. In fact, they are so common that the odds are extremely high that if you walked into my office on any given day and I performed an ultrasound on you, I would likely find a cyst if you are not currently on birth control pills or some other form of hormonal contraception. And the reason for this is quite beautiful in a biological sense. Our bodies are designed to create these structures every single month as part of the ovulation process. They are a normal, essential byproduct of the menstrual cycle. So let's walk through exactly what these cysts are and what they do. We are going to cover follicular cysts, which are essentially the follicles themselves. We will touch upon the corpus luteum, and we will also discuss those scenarios when you actually should be concerned, including endometriomas, solid-appearing cysts, polycystic ovary syndrome, PCOS, and what all of these things truly mean for your health. So, let's visualize what happens during a typical menstrual cycle. Deep inside your ovary, there is a vault or a reserve that holds a vast number of eggs. At the very start of each monthly cycle, a small group of these eggs emerges from that vault. Now, each one of those eggs resides within its own tiny, fluid-filled sac or structure, which is known as a follicle. At this early stage, these follicles are really, really tiny, often less than a centimeter in size. The brain then sends out a specific hormone called follicle-stimulating hormone, or FSH. This hormone acts as a growth signal, prompting one of these follicles to grow and mature. As that particular follicle is expanding, it is not just growing aimlessly. The egg inside is actively developing, and the follicle itself is functioning as a miniature factory, working diligently to produce more estrogen. Once the egg reaches full maturity, the rising estrogen levels trigger the brain to release another hormone, luteinizing hormone, or LH. This releases in a sharp, high peak, and this surge is the key that allows the now mature follicle to rupture. It is crucial to understand that the ovary and the fallopian tube are not physically connected. There is a small space between them. Therefore, for ovulation to occur, the cyst must actually burst open to release the egg, allowing the fimbriae of the fallopian tube to sweep it up and capture it. Immediately following this rupture, the empty follicle heals itself, transforming into a different type of cyst. It takes on a more solid appearance on an ultrasound, often looking homogeneous and grayish. This is because it now fills with different cells, primarily fat cells, and its new job is to produce a vital hormone called progesterone. This is the corpus luteum. So, the very same follicle and cyst that grew an egg and ruptured to release it now seals back up, and its purpose shifts to making progesterone, which is essential for supporting a potential early pregnancy. If a pregnancy occurs, that little cyst is rescued by the pregnancy hormone HCG, which stimulates it to keep producing progesterone to sustain the early pregnancy. However, if no pregnancy occurs, this cyst has a natural lifespan of about 14 days. Without HCG to sustain it, it simply dissolves, progesterone levels drop, and you get your period. In the normal course of a monthly cycle, these two distinct types of cysts, the follicle and the corpus luteum, often reach a size of around 2 centimeters. Now, we are still talking about very tiny dimensions here, and this is absolutely normal and healthy. It is essential to remember that the ovaries are somewhat free-floating in the pelvic cavity. They are anchored down to the pelvic floor by vessels that supply them with blood, and they have small ligaments connecting them to the uterus. This system provides 2 small suspension points, but it allows the ovary to move around quite a bit. So, when a cyst is forming on one side, you might experience some discomfort or pain. Our brain has a notoriously difficult time pinpointing, "That's my ovary," because the innervation or nerve supply of our pelvis and abdomen is not very precise. However, you may notice some weird cyclic pain every month, perhaps in the second half of your cycle, or right around the time of ovulation. Everyone experiences this a little bit differently. Often, this is just your body's natural way of signaling that it is feeling the presence or activity of the cyst. Now, let's talk about those follicular cysts and follicles rupturing. That is how you ovulate. Depending on exactly where on the ovary the follicle bursts, sometimes it can cause a small bleed. This means you ovulate, the cyst tries to heal back up, but if it ruptures right near a tiny blood vessel, bleeding can occur either into the cyst itself or into your abdominal cavity. So, if you have ever heard me or another doctor say, "You had a ruptured cyst, and it was extremely painful," or "We mentioned there was blood in your belly," or "You had a hemorrhagic corpus luteum," that means there was blood inside that corpus luteum. These events do happen, and while they can be quite painful, it's important to understand that they are often just a part of the normal physiological process. Typically, you do not require surgery for these. They heal on their own. However, the pain can be significant, and one of the management strategies we offer to patients who have experienced this and want to prevent it from happening again is to suppress ovulation. The cheapest and easiest way to do this is with birth control pills. These pills contain estrogen, which sends a signal to the brain to stop releasing FSH. If you aren't making FSH, you aren't developing follicles, and thus, you aren't ovulating. Your ovaries remain nice and small, with no big follicle growing, no corpus luteum forming, and no painful rupturing. This can be a very effective treatment for someone who has had a painful hemorrhagic cyst in the past or wants to avoid that discomfort. Imagine you go for an ultrasound due to some pelvic pain, or perhaps you have a CT scan after a car accident, and the report mentions a cyst. What I will often do is look at it and say, "Oh, look, there's a little cyst here." And immediately, that 4-letter word triggers alarm bells, and I completely understand that. We don't like to hear that anything is abnormal, but depending on exactly where you are in your menstrual cycle, that cyst could be a perfectly normal, healthy finding. While there are certainly times when a cyst is abnormal or appears suspicious, the vast majority of them are simply normal functional cysts. They are a part of the ovulation process, they are common, and they are absolutely essential for the production of our reproductive hormones. Now, let's dive into some other types of cysts more quickly. The first is polycystic ovarian syndrome, or PCOS. The name itself includes the word cystic, and I have to say, I really dislike this terminology because it leads to so much confusion. I have a separate, full-length video on PCOS with plenty of content about it. Essentially, PCOS is characterized by having an abundance of eggs inside your ovary. What happens is that when the vault releases a high number of eggs each month, you end up with a high follicle count. An ovary full of these follicles, which are technically tiny cysts, gives the classic appearance we call a string of pearls on ultrasound. It looks like the outside of the ovary is lined with all these little black pearls. Those are cysts, yes, because they are fluid-filled structures, but truly, they are not the problem. They are just a visual finding. These tiny little cysts are not harmful to you, they are not worrisome, and you don't need to follow them or have them surgically checked. Now let's move on to a category of cysts where we do need to be more vigilant. One of these is the cyst that can occur with endometriosis. Endometriosis is, in my opinion, my absolute least favorite reproductive disease. It is a truly challenging condition. For an endometrioma to form, the normal process unfolds. An egg comes out of the vault, a follicle grows, matures, and ruptures to release the egg. However, in this scenario, cells similar to the endometrium, the lining of the uterus, which are implanted outside the uterus, the hallmark of endometriosis, manage to get inside the ovary during that process. When the corpus luteum forms, these endometrial cells are trapped inside. Once they are in there, they absolutely thrive. They love the environment. It's warm and has a rich blood supply, so they just proliferate like crazy. These endometriomas can cause significant pain, they can decrease your egg count, and removing them can be extremely difficult surgically. Because of these complexities, we don't always rush to remove an endometrioma. It's important to know that if you have one, you automatically have stage 4 endometriosis, which is the most advanced stage. Typically, endometriosis is a surgical diagnosis, which means we usually need to go in with a camera to definitively say you have it. However, the one exception is that an ultrasound finding of an endometrioma can confirm the disease without surgery. If we see that on an ultrasound, we know for sure that you have endometriosis, and we know you have stage 4 disease. When we think about patients with endometriomas, I want to ensure they are fully aware of the potential complications. They may encounter situations where their pelvic anatomy becomes scarred or distorted because of this advanced stage disease. They might also experience a drop in their egg count. Therefore, we really need to think strongly and proactively about their family planning goals. In general, most of the time, we actually prefer to proceed with advanced fertility treatments without removing the endometriomas first. We know that taking them out will likely cause a decrease in ovarian reserve due to the scarring that occurs alongside them during surgery. So the take-home message here is crucial. If you have stage 4 endometriosis, or if you have an endometrioma, you absolutely need to have a comprehensive consultation with a fertility specialist to make a well-informed plan. For my patients with endometriosis, I often advise them that there is no middle ground that I feel comfortable with when it comes to ovulation. Every single month that you are ovulating but not actively trying to conceive, we are essentially allowing an opportunity for more endometriosis cells to get into those follicles and create a new endometrioma, which provides us with absolutely no benefit. Now, let's discuss another type of cyst that can form, which is called a dermoid or teratoma. These are incredibly fascinating cysts. They originate from germ cells, meaning they come from different cell lines that haven't fully differentiated yet. As a result, they can contain a bizarre array of tissues, such as hair, scalp, teeth, and fatty material. They are truly wild. The good news is that these are almost always benign, meaning they are not harmful or cancerous to your body. They have a very classic, recognizable appearance on an ultrasound. You can often see calcifications, which might be teeth or bone, and other distinct structures. However, they can still cause pain, and depending on their size, they can grow over time. The main risk with a dermoid is that they can make the ovary larger and heavier, putting it at risk for ovarian torsion. Unlike the normal functional cysts that come and go and don't make the ovary significantly large, once an ovary gets bigger than about 5 centimeters, especially when it's filled with dense fat, it can bounce around inside the pelvis. This bouncy, heavy ovary can twist on itself, twisting off its own blood supply. This is a surgical emergency known as ovarian torsion, and it might require immediate surgery to remove the ovary. So, with a dermoid, we don't always take them out, but we will often monitor them for growth. If they are getting bigger, or if they are causing persistent pain, those could be clear indications for surgical removal. Finally, we have cysts that sit on the spectrum between potentially benign and potentially malignant. Ovarian cancer can present as an ovarian cyst, but it's a very difficult diagnosis. Many cysts that can mimic cancer on an ultrasound are actually completely benign cystadenomas. It's important to know that some signs of ovarian cancer often have nothing to do with a localized pain in the ovary. Our brains just don't conceptualize ovarian pain that specifically. Instead, I want you to think about some broader, more systemic symptoms. These can include unexplained weight loss or gain, persistent bloating, awakening in the abdomen, fatigue, and gastrointestinal distress. Sometimes the cancer creates extra fluid in the pelvis. It's not just feeling bloated after a large meal, it's a constant feeling of fullness, bloating, and your clothes getting tight without explanation. If you carry a genetic disease that predisposes you to ovarian cancer, such as the BRCA gene, you should be getting monitored regularly because you are at a higher risk. When we look at a cyst on ultrasound, we categorize it as simple or complex. A simple cyst has an interior that appears to be only clean, simple fluid. These are almost never cancer, less than a 1% chance. Complex cysts, however, have a variety of different architectures and solid components or debris, which are more suspicious. A complex cyst could be a hemorrhagic corpus luteum that will resolve on its own. It could be a dermoid, or it could be cancerous. So, if the nature of a complex cyst cannot be easily determined, it absolutely needs to be investigated further. If you hear that you have a simple cyst, that's why we aren't panicking. We usually just recommend a follow-up ultrasound in a few months to ensure nothing is changing. I have personally seen patients diagnosed with ovarian cancer on an ultrasound that was initially performed for a fertility evaluation, so I take these findings very seriously. If you have a family history of ovarian or breast cancer, or if anything seems off or concerning to you, please get it thoroughly evaluated. I truly hope this video has helped to clear up some of the confusion and anxiety surrounding ovarian cysts. As always, I appreciate each and every one of you for being here. If you found this helpful, I hope you will subscribe to the channel and feel free to explore these other videos for more empowering information about your body. Thank you, my beloved friends.